You have been diagnosed with cancer and need surgery. This is what we're going to talk about this evening on Focusing on You. Welcome to Focusing on You. My name is Heather King. I'm the Educational Director with Hope Abounds. Tonight we have Dr. Gregory Bebb, who is a local surgeon here in Wilmington, North Carolina. He's the director of the breast center at Wilmington Surgical Associates, but his focus is breast cancer, melanoma, and thyroid cancer. So we're going to talk to Dr. Bebb tonight about how a surgeon plays a role into that cancer diagnosis. So thank you, Dr. Bebb, for joining us.
Thank you for having me.
This evening. I'm sure that all the patients are very excited just to hear a little bit more about the surgeon and the role, because they just received a diagnosis and then they don't know where to go from there. So from a surgeon's perspective, and you have a newly diagnosed patient, what does that look like, the appointments and the discussions with the patient?
There are a lot of complexities there because there are different members of the team.
Sure.
And I think it's important to set a perspective for the patient of who's going to sort of quarterback their care. There are many people involved, but before I even get involved in that, I think I want to give people a sense that, and to coin a phrase with the group here, Hope Abounds for breast cancer. And so I think that's important to let them know this is a very manageable problem most of the time with curative intent. And I think that helps the patient be able to hear the rest of what you say.
Right.
Because if you start with all the details and then you get to the fact there's really hope, well, they weren't listening until you heard there was hope.
Sure.
So I think I try to get that out first and then begin to introduce them to the general concepts that they need to know, that there will be likely a surgeon involved that specializes in cancer surgery. There'll be a medical doctor who uses things other than just the dreaded chemo. There are oral drugs, radiation oncologists. There are plastic surgeons dedicated to the cosmetic preservation and life form that the patients are interested in.
Sure.
There's geneticists that are important, as you know, and there are physical therapists that need to be involved in this equation, and where they come in, how they come in. I think it's important for me just to let them know at the outset, I'm going to take care of managing these appointments for them.
And that's wonderful, because it is overwhelming, and sometimes they do hear that cancer diagnosis and then everything else from that point forward kind of they don't hear. So I know that you have a great group of nurses that you work with as well that definitely work hand in hand with you to help with patients. Your staff is amazing. So on top of just the doctors, I'm sure you have nurses and medical assistants that really help out as well.
Yeah, I think it's important to have a team that loves people and are good at what they do. If you have only one of those two, you're probably going to have the incomplete package. I'm very blessed over the years to have had people that have been providentially brought to me, and I'm grateful. And my nurses have been wonderful. My administrative assistants are great. Medical assistants, I really couldn't complain about any of them. We have great ultrasound technicians, and they buy in to the patient first idea. And I think the patients sense that early on, that there's a bit of a family feel when you come. Now, can we achieve that on each and every patient, or do we execute that with excellence each and every time? That's our goal, but much like the human life, you know, I'd say we fall short at times, but that's our goal.
No, that's great. And oftentimes the patient might call and they're not obviously going to get you every time or talk to you every time. And so it's important that your staff, as you said, has the same philosophy of that patient first as you do. So just talking a little bit about patient first, what is your philosophy of care for this newly diagnosed patient and the whole surgery aspect?
I think the philosophy of care is very important because I think it drives a lot. Somewhere, I think, in the heart of every person, there's something driving them to do what they are doing. And for me, the drive ultimately at the end of the day is to glorify the Lord Jesus Christ. And I think he gave us a very simple formula once in his earthly ministry to love God and love people. And I let people know, usually somewhere along the way, that is my motivation and that it actually works out best for them. Because if I was motivated for them first over the Lord, that would be to get it backwards. But if they're caught up in a relationship between me and the Lord, and I love him and I want to take care of this person that he knows and loves and is fashion and formed, and that I'm responsible for caring for this person that he has brought to me, then there's a much higher sense of duty, an eternal sense of duty, and I think that drives a lot. Does that get communicated in every circumstance? Is every patient particularly interested? Would their worldview mesh with that? Not always. So I have to be sensitive to how I communicate that. But behind the scenes, that is what is the driving force for me as a Christian, trying to execute great quality breast cancer care. I remember a great story by an evangelist named D.L. Moody in Chicago, who was a very unusual guy. He made shoes, but he was also an excellent preacher. And people spoke about why he took so much detail on every shoe. And they said, well, look, these shoes are going to wear out. Not everybody cares about shoes as much as you do. Just make the shoe.
Right.
And he said, yeah, I pictured my life as being a mountain of shoes. I didn't ever want the Lord to pick up one and say, you didn't do your best here.
That's amazing.
And so I want to do my best, which in each and every person who's more important than a shoe.
Oh, absolutely. And you know, you truly are a blessing to this community. And that philosophy is amazing, and one that not every patient might embrace, but it's, I know personally, you know, I've been a patient of yours, and for me, it made all the difference in the world. So,
I'm grateful.
Yeah, no, I'm grateful, and so are the patients. So what type of, getting back to a little bit of your schooling, in the beginning, I didn't go through every certification that you have and every fellowship and everywhere you've gone to school, but you've done a lot of training. So from a surgeon's perspective, especially one that has the fellowship training that you have within breast surgery, what does that path look like?
It's a long one.
It's a long one.
And a lot of hours. Some of those mechanics have changed over the years, probably for the better. The 103-hour work weeks that I remember in surgical residency have faded back to 80. Although people in my era say, oh, well, we did it the tough way, I think 80 is probably much better for the doctor and the patient. It involves, of course, college, completing a degree in college, typically a 4-year format, and medical school is 4 years as well. Then there's a surgical residency that has a variable length to it. I did 6 years of that, and then I did a surgical oncology fellowship. Oncology is a fancy word for cancer. And that had broad training, including abdominal cancers, liver, pancreas, lung, all sorts of things, not just breast, melanoma, and thyroid, which I chose to focus on. And that can last anywhere from 1 to 3 years by choice. I picked a 3-year program that I was particularly interested in. I thought the lengthier time would probably allow me to hone the skills better. And then you're ready to go out and hang your shingle.
A lot of training.
But you think you know a lot when you're done with all that training, but the Lord has a way of humbling you along the way, and the patients become your continuous educator. And if you keep your ears open, you're going to learn a lot in the course of your practice just listening to people.
Sure.
And then there's ongoing training. There's been changes that have occurred along the way, and we have to reach out to people that can help us. You were a great help to me as I got educated in understanding the role of breast cancer genetic testing for the breast cancer patient. That wasn't something that was ingrained in me in training because it was really not a technology that kind of aged 22 years ago. And I've been interested in applying new technologies, particularly to breast surgery. So we've incorporated what is called oncoplastic surgery that when I was done training hadn't even been done, but a particular plastic surgeon in town, Dr. Charles Kays, and I got involved in this 15, 16 years ago and began to think differently about how to allow the patient to come out with good form and symmetry. It wasn't a great sense of well-being for a patient to come out with an asymmetric outcome, right breast versus left. And so we've worked very hard in that regard. We have built lumpectomies into breast reductions that help. We've completely redesigned implant reconstruction after surgery so that now implants are usually not placed behind the muscle that has to be stretched, and that's a two-step process, to a single operation that Dr. Charles Kays has actually pioneered, and it requires some crosstalk between the cancer surgeon and the plastic surgeon, because the cancer surgeon has to remove the breast in a certain way to preserve the skin envelope for Dr. Kays to work with. And then I've been working with putting in a implant myself in the regular lumpectomy cavities so the patient doesn't have a divot, if you will.
Sure.
So those things are all exciting. We've seen something called sentinel node mapping, which we've applied over the 21, 22 years here that hadn't been done at all in Wilmington. And that's been exciting because we've avoided complete lymph node dissection for 80% of women with breast cancer. And so we're excited about that. But I continue to learn. My physical therapy colleagues teach me about arm swelling and lymphedema and ways to prevent. We have tumor boards with radiation and medical oncology. So my ears are open, and we're constantly reading and adapting strategies.
And that's amazing because things do keep evolving, which is wonderful from a patient perspective, that they're getting the best care that they can. I remember, it's been a long time ago, but when my grandmother had breast cancer, really the only option was just having the cancer removed. There was no reconstruction associated with it. And from a woman's perspective, that definitely changes the way that you feel and you think about yourself. So, I mean, you've brushed on it a little bit, but care has changed dramatically over the years and what can be done. When you first started, I'm sure it was a very different picture compared to where you are now. What has been the biggest change that you've seen throughout when you first started to now from a patient's perspective?
I don't know if I could give a biggest, but I'll throw a few out.
Yeah, absolutely.
I think the reconstructions have magnificently improved. The implants have improved. The ability to place them on top of the muscle has improved. The outcome and the aesthetics have definitely improved. I think that's one. The use of breast reduction for a woman who's large has greatly improved the outcome of lumpectomy, because those women would have an injury to their breast. And if the breast was large and hanging, if you will, it was sort of like a cardiac patient's leg, always down and swollen. So to elevate that breast and allow it to have better cosmesis, a better look, and better drainage, gave them a better quality of life. So that's a second. A third that's dramatically changed has been the use of molecular profiling of tumors that has eliminated chemotherapy for about 3/4 of women. When I came to town, any woman with a breast cancer, usually 1 centimeter or more, got chemotherapy.
Right.
There was no individualizing of it. There was just this 1 centimeter cutoff. And now we have particular genetic markers and tumor profiling that's done on tumor samples that have told us that most of those women really will not benefit from chemotherapy. And they do much better on hormone therapy. which is actually anti-hormone therapy, but we call it hormone therapy, but it works against estrogen. And so I think that has changed a lot. Less hair loss, less chemo, better surgical outcomes, I think has really been transformational.
So those genomic markers you're talking about, that's an actual sample of the tumor that's sent away?
Correct. So cancer is basically a set of genes that you were born with normally that have gone bad in life. Now, breast cancers are like terrorists. They're not the same. Some of it depends on what country they're from. And so you're trying to find out what country this terrorist is from. And is it a very hostile terrorist or more of just a upset fella?
Right.
And the genetic markers allow us to look at mutations on the tumor sample. So when we do a breast biopsy, we pull out little plugs of tissue. And one of those plugs can be submitted to a lab that will actually break down the DNA, categorize the genes in there, put it into a data bank that has been investigated in the past for women with chemo or without chemo, and we can see, based on history,
Right.
what has happened in the past with a woman with this very particular terrorist. What has happened when it's gotten chemo or not. And if you see a big difference, well, chemotherapy becomes important as long as you can tolerate it physically.
Sure.
And if you don't see a difference, which is what we usually find, then chemotherapy isn't applied. And that's usually met with a lot of joy by the patient.
Oh, absolutely. So that biopsy can be done in your office.
Correct, yeah. Breast biopsies rarely should be done in the operating room.
Okay.
That's a big change. And that's important for a patient to know. If they have an indeterminate finding, they should take every effort to have a little probe put in the breast to do the biopsy. Going to the operating room and having the tissue cut out is absolutely the wrong way, because that fouls up the eventual surgery. That messes up the cosmetics, the plastics. It messes up the lymph node mapping and the staging. It's occasionally necessary to get the answer that way, but rarely necessary.
Well, and that's great from a patient perspective that it can be done in your office and knowing that the outcomes are going to be better in the long run. Is every patient sent away for these genomic markers that you do a biopsy on?
Yes, no, not every patient is sent away. So tumors fall into two major categories: those that are sensitive to estrogen or the hormone, female hormone estrogen, and those that aren't. If the tumor is not sensitive, those are more aggressive, and this oncotype test is not helpful.
Okay.
The other group of tumors are ones that bear a protein called HER2, a little protein on the surface, and those that do not. Tumors that have that protein are more dangerous, and they get chemotherapy almost all the time. And so we don't send oncotype if the tumor is lacking in estrogen receptors or has a HER2 protein. Now, that being said, most cancers have estrogen receptors and do not have the HER2 protein. So most women are candidates for having this profile. Now, it has its best track record in women that have clean lymph nodes at the time of surgery. However, there are smaller data sets looking at women with minimal lymph node involvement having just about the same ability to use this information to avoid chemotherapy. Essentially, this is a test to figure out if you can avoid chemotherapy.
Which is ultimately wonderful if it can be done.
Yeah.
So when you do the biopsy, you send it to the pathologist, and the pathologist comes back and tells you about these different receptor activities, correct?
Correct. We'll know about that the next day.
Okay. That's pretty quick.
Yes.
It's very quick. So if a patient first comes in and talks to you and you decide to do a biopsy, what is normally the timeline if they do need surgery that you can get them to surgery with every step that needs taken with, whatever you're doing as far as all the other tests?
Usually 3 to 4 weeks. And I think it's important for patients to acclimate to the new diagnosis. I think there's a real tendency to think I need to be in surgery tomorrow because it's going to explode in me like a water balloon.
Right.
And that's not the way these things work. And so it is important for them to be properly informed and educated, particularly when they have a decision between having a lumpectomy with radiation or a mastectomy, usually without radiation. They need to learn the pros and cons of those two since they are considered equivalent therapies, but they have a choice to make. Now, it's my job to educate them because oftentimes the patient is a deer in the headlights. But one of the ways to educate them is to give them a few days, a week or so, get their feet on the ground. But typically 3 to 4 weeks. And I think that's good for the patient.
Sure, absolutely. And even if it is a faster growing tumor, that 3 to 4 weeks is perfectly acceptable. It's not
Yes.
going to change the outcomes.
Yeah, 3 or 4 weeks is not changing the outcome of breast cancer.
Good. And that's good for a patient to know because, as you said, sometimes people will find a mass and they'll say, okay, I want it out yesterday. And it might not be the best decision for them to do that. They need to plan and think, as you said. So.
Correct.
We talked a little bit about tumor boards. We touched on that a little bit, and we've talked about that with some of the other Focusing on You discussions that we've had in the past. So you do participate in tumor boards. Can you explain a little bit about tumor boards you participate in, and from a patient perspective, how the patient would be brought into a tumor board and what that discussion might sound like and what professionals might be in the room?
So a tumor board is a board of individuals, just like a business has a board. And that board of individuals has a broad representation. Usually there are surgeons that do the operations. There are medical oncologists that give the chemotherapy or the endocrine therapy. There are radiation doctors who treat with a radiation beam, if you will. There are physical therapists that occasionally attend, but not frequently. There are nurses involved in collecting data. The hospital keeps particular information on the outcomes of breast cancer patients, so there are those administrative individuals there. There's always a radiologist to review the mammogram, the ultrasound, the MRI, the PET scans, the CAT scans, the bone scans, the x-rays that we need to look at. And there's a pathologist who will bring the slides. So it's a really stimulating environment for me. I love to hear the collegiality, the insights, and there are articles being written in all these different disciplines weekly. And so there's probably not a tumor board that goes by that I don't learn something. Even if I've taken care of thousands and thousands of breast cancers that I have, there's still things to learn. And your colleagues bring a lot to the table. How does a patient get their case on there? It's usually the doctor brings the case, and typically the surgeon will put it on, but the medical oncologist and radiation oncologist do as well. But because we're often the initiator and the point of care, we're bringing those cases. And we're bringing cases that have some difficult or gray zone questions that should be asked, where you can make decisions one way or another, and both ways would be considered legitimate standards of care. So these are nuanced cases.
Right.
Cases where you really want to be clear what the pathology showed, or what the radiologist meant by this finding, or what the real benefit of the chemotherapy is. And then another participant in these tumor boards is the research trial nurses at the hospital. So we do enroll patients in clinical trials. We've been enrolling people at New Hanover in trials regarding axillary lymph node surgery. We're about to launch a trial using MRI for breast cancer evaluation. And they are there to help us figure out during these conversations who fits into what trial. Because the trials do have some elaborate schemes on who gets in and who doesn't. And so they can help us make sure that we mention these trials to people if they're due candidates.
Sure, and not every patient is a candidate for a trial, but if they are candidates, then that would be something that would be discussed.
Correct. Yeah, and most people are really not candidates for clinical trials. And part of that is because we've had so many breast cancer patients in this country, 40,000 to 50,000 new cases a year.
Wow.
So many women have been enrolled in very well done trials. In fact, this Oncotype study, this genomic study I told you about, is about to unleash data on one of the largest trials ever done in breast cancer in the world, and that's coming up in the next month. But most of this has been pretty well worked out.
Right.
So the trials have very particular goals for very particular types of patients.
No, and that's just great to know that that's an option. It's something that locally we are participating in and is being discussed for
Yeah.
sure. So it's even though Wilmington is a smaller community, there's definitely a lot of cutting edge stuff going on with individuals such as yourself and the rest of the treatment team. So it's great for patients locally for sure. We talked a little bit about lumpectomy and potential reduction versus a more aggressive therapy, and that sometimes that you do truly give the woman a choice. Are there what I guess determines for you how that discussion goes?
I want them well informed, and I use pictures a lot. So it's very common for me to take patients to a computer and show them pictures, because I find if I just sit in the room with words, I've lost them often. And so actually I'm very thankful for iPhones. So I'll use pictures off of Google and show them pictures of what I'm talking about. And I find that to be very helpful. Dr. Case, the plastic surgeon, does the same. The radiation doctors have videos for the patients to watch. So I do think when the people are lost, the picture can sort of help them orient their focus.
Right.
So I think educating them as to their options and benefits. But ultimately, you are steering the patients. Some patients are very clear what they want. And some people come in and say the day they get breast cancer, they want bilateral mastectomy. And other patients know the day they hear breast cancer, they want as little surgery as possible, or maybe even just forget the whole thing. They don't want to do anything about it. So people do come to you
Sure.
as individuals, and that's part of the fascination of medicine, is how to communicate standard information to a wide variety of people coming at it with many different philosophies. Your philosophy and their philosophy are going to have to learn to merge, like merging two phone calls.
Absolutely. And sometimes I'm sure it takes patients a little while to get to that, even if you are trying to give them all of the information that needs to be given to make a decision, I'm sure. So some patients think that this is a little bit of a delicate subject, but from a surgeon's perspective, how do you feel about second opinions?
Yes, I encourage second opinions. In fact, I often talk to people about that. And what I have found is that when a patient has breast cancer, everybody wants them to have the best thing done for them. So there may be some relative in Nebraska or in France, and they all think they have something important to say, and they do. And they'll say, well, look, it's important to get a second opinion. The vast majority of my patients don't really seek a second surgical opinion. They feel fairly content as they meet the radiation doctor and the medical oncologist that's sort of built in there. They've been talking to people with different perspectives.
Sure.
But some people would like to hear from an entirely another team. And I encourage that as well. I always tell the patients, like, you are going to go into the operating room once.
Right.
You better be content. And you better have a deep sense of security with the team that you choose. And one thing I encourage people in my own practice, and I actually bring up the topic of second opinions, because I think sometimes people are intimidated. Like if they bring it up, that you'll be upset or offended. And that's one place where I think being a Christian helps, because my esteem is not caught up in this particular patient using me as a surgeon. It's in honoring the Lord, and for this patient to go the course He wants for her.
Sure.
And so I want her to be in the best hands possible. And that does involve not just somebody with good skill, but somebody they're content with. And I'll say to them, look, just to break the ice on the topic and say, look, it's sort of a common philosophy out there to get a second opinion. Feel free to do it. I can help you pick a second opinion. I can make referrals for you to do that. I try to make it very easy for them. And I don't want you to feel like if you have a second opinion, oh no, I like Dr. Bebb. I feel like you're offended. Maybe I can't come back to him.
Right.
So I let them know the door's wide open. Get second opinions. Come back if you like. Be happy to do it. I am grateful that it rarely is a case the patient really does go off and do their care somewhere else. But if they do, that was best for them.
Right. Well, that's wonderful, because sometimes, I think that patients want to be able to hear that and know that it's okay. So I think it's amazing how you actually bring it up and break the ice. I personally don't know why anyone would want to go to anyone else, but
Thank you, Heather. I appreciate that.
Personal perspective. So after you perform the surgery, how long do you follow your patient with breast cancer?
That's a good question. And then again, that's a patient-physician relationship discussion. Usually I'm following the patients for life. They can recur anytime, but some patients just prefer not seeing me after 5 or 6 years. For some people, just driving into my office is post-traumatic stress disorder. They remember the day they were diagnosed or something, and they'd rather do their follow-up with their primary care doctor, who they may feel less intimidated. Although what I've found normally is, after a couple of years, people actually do not want to be released after 5 or 6 years. Somehow it's a security blanket to come back and have me review their health history and do a physical, make sure there's nothing that's recurred, and review their mammogram or ultrasound that they need to have done. So it's, although the intensity of what I do for them is caught up in that first year of care, I do enjoy the relationship, and I sort of try not to let people go. I really enjoy seeing them every year. But as people get older, they have lots of problems. They're seeing the ophthalmologist, the knee doctor. They're seeing the medical oncologist and me. Do they need two for the same breast cancer diagnosis? So I have that discussion ongoingly with patients, but pretty much I try to keep them in my sphere of observation for 5 years. But I leave the door open to follow them for life.
Sure. Well, that's great for continuity of care for the patients if they choose to do that. How often do patients come back where you actually do have to operate on them again, whether it's the same breast or a different tumor type in the other breast, if they chose to do a lumpectomy or something like that?
So some of that you can narrow down more, because some women are more at risk than other women for getting second tumors. Because I do things other than breast cancer, people come back to me for gallbladder surgery or hernia surgery or some other thing that I do, melanoma, thyroid. But that notwithstanding, I think that just to your question is, how often do you have to reoperate on the breast?
Yes.
Or with regard to breast cancer? And I would say that's probably in the 5% range, 1 out of 20 patients. And that's fairly consistent across the board nationally.
Absolutely. I'm sure that it's rare, but it can happen. Yeah, for sure.
More of what I find I'm doing are confirmatory biopsies. They may feel a little nodule, or the edge of the scar is different, and I'm putting that probe device in that I mentioned earlier for a biopsy. So I'm doing those sorts of things. But if we're talking about going after recurrent breast cancer that's somewhere around the breast or lymph nodes, that's probably a 1 in 20 ratio.
But I'm sure it's comforting for the patient to at least know that you're there to do the biopsy if that's needed. And that same biopsy would be sent off to pathology to confirm whether it was benign, so was not anything that was cancer, or whether it was pathogenic, which is another cancer.
Right.
So,
Yeah, you go right back to the beginning.
yeah, back to the beginning, which we hope does not happen
Right.
to patients, for sure. So how we've talked a little bit about how surgery has changed through the years, and we've talked a little bit about technology changing and everything changing, but even from a surgical perspective within what you're doing, have you seen a specific change in how the surgeries have been done from before until now? And I know we touched on it a little bit in the past.
Well, I don't want to beat a dead horse, but
Yeah.
the breast reduction is a big change, as opposed to just making a cut and taking a tumor out.
Sure.
Making a cut and taking the tumor out was the way we used to do it. Now we make a cut and put a little implant in that lasts 2 years and dissolves.
Wow.
That's for the regular lumpectomy, and it preserves the shape during the radiation. The surgery has changed from removing all the lymph nodes to removing a few with dye testing that we do. The surgery has changed from using tummy fat and fairly big flaps to reconstruct breasts to where that's rarely done except for salvage circumstances or second operations or people who've been radiated. So that's sort of fallen out, and now this implant on top of the muscles come in. The surgery has also changed in some of the tools that we have, particularly taking all the lymph nodes out under the arm. It used to be done with a standard surgical procedure with little metal clips and scissors and electrical cautery. And now we have a very fascinating ultrasound machine that will literally take little bites of tissue, rub it together, coagulate it, and divide it, so that the surgery has become fairly much bloodless now.
Wow.
And I think there's less swelling under the arm because of it. So those are some of the core changes that I've seen over the years.
That's amazing. Obviously, things just keep changing, will continue to change, but doing additional education and going to different conferences definitely assists in you being cutting edge.
Mm-hmm.
And so is there anything else that a newly diagnosed patient that you really want to make sure that they understand from a surgeon's perspective?
Well, I think people don't think of breast cancer in a box, just them. They're wondering what's the impact on their children and their grandchildren. Mm-hmm. And they're trying to figure out how to have that discussion with them. What risk does this put them at? So I do think we have to broach those topics along the way. And there are people who are appropriate candidates to investigate to see if they have inherited a gene mutation. Now that's very different. Of course, you know this, Heather, but for the audience's sake, when we talked about gene mutations earlier and looking at which ones benefit from chemo and don't, that's looking at things that have gone bad in life. When we're talking about inheriting, we're saying you've received something either in your father's sperm or your mother's egg that is now a part of every cell in your body, but puts you at risk for specific tumors. And these are typically defects in your body's natural ability to fix mutations. Mm-hmm. And so most people have Scotch tape in their house and they can fix things. Some people don't have Scotch tape in their body and they can't fix these things. And we're trying to figure out who's missing the Scotch tape. So I do think that is an important part for the patient, particularly before surgery, because if the patient carries one of these mutations, now we have a big discussion. Mm-hmm. Because we're not talking about a strategy just to treat this cancer. We're talking about a strategy to prevent high likelihood second cancers.
Right.
So there's two features involved there. I also find that it sometimes will bring a woman back who comes in saying, breast cancer, forget it, they're both gone. And I can understand patients, but sometimes after they've had that 2 or 3 week period, they've met the other team members and their genetics come back negative, that cools their jets a little bit, and they all of a sudden become much more amenable to the conversation of lumpectomy.
Sure.
So I do find that genetic testing helps both ways, and I think it helps the daughter who's sitting in the corner wondering, what's this mean for me? Mm-hmm. And the granddaughter who's off at college or is wondering, what's this mean for me? And so there is a trickle-down effect of these diagnoses in the family. There's a reason we take family history, right, when we talk to patients.
Right.
And that applies to heart disease, stroke, cancer, and the like. So I do think that's important for the surgeon to be involved in that. He's got to bring that piece of the conversation, when appropriate, into the dialogue.
And that test is just a simple, it's not like a biopsy. It could be just blood or a saliva test.
Correct. Very simply obtained in the office. I think people have to be educated as well. They're afraid that if this information is known, they won't be insurable or be able to get insurance. And so you have to tell them, no, there are legal protections for that. I do think it's important to have a little discussion with the patient what they would do with the information, because some people might not handle that particularly well. Mm-hmm. But I find that to be the exception, Heather, rather than the rule, as I think you probably have found as well in your tour of duty in genetic care, that most people can handle the information. They're big boys and girls,
right?
And they'll work that into their understanding just fine.
Especially if they're dealing with a cancer diagnosis, it's a piece of the puzzle that hopefully will change care, and they won't have to come back again for another surgery or have to deal with cancer a second time. That's
a great point about changing care, because we've always thought about genetic testing as changing care from lumpectomy to mastectomy bilateral in terms of treatment and prevention. But it also is beginning to impact chemotherapy decisions. Mm-hmm. So women with breast cancer gene mutations sometimes have shown a better benefit from particular chemotherapy agents chosen. Now that's a little out of my bailiwick. That's for the medical oncologist, but of course I'm part and parcel of that conversation. And it is important for me to get that information to my medical oncologist. I have to know this is important. So when the patient arrives on their doorstep, I want them to have the information they need to have an efficient visit. I don't want them to have to come back twice because everything wasn't there.
Sure.
So knowing that breast cancer genetics can impact the chemotherapy choice, I think you have to know when you need to order it for that purpose, which is a newer wrinkle on the genetic testing scene.
Absolutely. And I think things will continue to, whether it's genetics or therapies or surgical options, I think everything will continue to evolve over time. And it's just amazing to see in the time you've been around some of the changes that have happened and will continue to happen. So from a patient perspective, it's just nice to know that things just keep on getting better, hopefully. So it's interesting because the theme just keeps coming back to this circle of care, and a surgeon, pathologist, medical oncologist, radiation oncologist, everybody's part of this true circle of care, and it's nice just to see that communication going on. Even if they're not in a tumor board, you're still as a surgeon helping that patient navigate through all of that, because it is kind of daunting from a patient perspective, for sure.
No question. And there's two ways to build this circle of care. Some centers, breast cancer centers, particularly in the university setting, have been committed to the model that the patient sees all the doctors and the entire team on the same day. And that has its allure. It is attractive to think that the patient can get up to speed in a day. We've had a different model in New Hanover where they'll see me one day, the radiation doctor another day, and the medical oncologist another day, and the plastic surgeon another day. Sometimes there'll be 2 visits in a day. I've found that the patients who've gone off for second opinions where it was a flurry of activity in one day, they came away not remembering who said what or what purpose. They were so confused because they really didn't digest visit A before they were thrown into visit B. And I think settling the patient down and saying, look, we have some weeks to pay. You need to go home and cry. Do that.
Right.
And then come out ready.
Yep.
And you need a visit with the surgeon one day and the medical doctor another and the radiation. I think it's better because they can digest, meditate upon what they've heard that day, and then carry forward and add another layer to it.
Sure.
I think the idea of doing this to a patient all in a day is sort of a formula to see a house of cards fall.
Right. It's a lot. It's definitely a lot. So as a surgeon, and it's pretty typical for surgeons to organize all of the other specialties of physicians that are being seen, is that pretty much standard?
I would hope so.
Yeah.
I do think that's an important role for the surgeon, since he's the initiator, to be the quarterback.
Sure.
And so yes, I see that as my role.
Wonderful. Well, this has been wonderful just to be able to talk about what a surgeon does, what you do for your patients. Do you have any parting words for our, Hope Abounds audience that's watching today?
I think there's hope, and it abounds in breast cancer. It is one of the most hopeful cancer diagnoses to get, but I would hope that you wouldn't have this diagnosis in the audience. But if you do, I think it's important to realize there's much that can be done, even for patients who have stage 4 disease, where it's in their liver and bone. I've got many patients who are living years upon years, almost like they're living with high blood pressure. They take this medicine, and they have an achy bone, or their diet's a little off, or they have these headaches, but they really can. Now, there's no question there are people dying of breast cancer. That's a reality. But 80 to 90% of patients are living long, enduring, functional lives. Quite frankly, I've found patients say, and I even have a patient who wrote a book, that it was one of the best things that ever happened to them. So many things that they had used to focus their life on got thrown to the curb, and things that had more eternal value became more central in their lives. And so I would say there's a lot of hope in that the Lord can use these things for good.
No, it's an amazing message, and thank you for
You're
your
welcome.
time tonight, and really trying to help the patients, all of us, understand better what a surgeon does. And I just wanted to say thank you to the entire audience that's watching this Focusing on You. There are multiple different discussions to be had that have gone on in the past, and definitely want to make sure that you're empowered. Knowledge is power, to understand exactly how you can move through this newly diagnosed, your new diagnosis. So thank you very much for your time tonight. And on behalf of Hope Abounds, we hope to see you again soon.